So I'll begin with the usual clinical update, which gives you the figures as of 4 p.m. on February 5th, 2021. In terms of our tests so far, at both public and private facilities, we are at 86,295. Over the last 24 hours, we would have reported no positive cases. We have a total, leaving our total standing at 7,607 since the 12th of March. With regards to our recovered patients, we have 7,242. Our active caseload now stands at 230, and deaths remain at 135. With respect to our hospital population, we have seen some decline, going down to 28 persons in hospital at this time. There's no one in our step-down facilities, and a total of 346 persons in our quarantine sites. The number of persons in home isolation stand at 202. With regards to our hospital, again, 28 persons spread among 2 or 3 facilities. At the Couva Hospital and Multi-Training Facility, there are 18 persons, 3 of those in ICU and 2 in the high dependency unit. There are 9 persons in Cora, 1 in Scarborough General Hospital at Signal Hill. With regards to quarantine, again, spread among many facilities. At the Cape Park Hotel, we have 86 persons, Cascadia Hotel 32, Paria Suites 8, the Chancellor Hotel 21, Tradewinds Hotel 21, Cara Suites 12, Freedom Hall 21, Debe at UWI 22, Napa 27, Regent Star 51, and Homer Football 26 persons. Our ambulatory total percentage now stands at 9%, ICU capacity stands at 13%, and the high dependency unit at 4%. If we could go into my first slide, which gives the total number of active cases spread among all the counties in Trinidad and Tobago. We see that the highest level now remains St. George East at 24.7%, followed by County Caroni 19.5%, St. George Central 13.8%, Victoria 18.4%, and the other counties have gone down significantly. St. George West at 8.6%, St. Andrews, St. David 6.9%, Nariva Mayaro again very low, 0.6%, same as Tobago, 0.6%. So we see in the highly populated, the East-West corridor, which is expected, you have the highest number of cases, but the number of active cases remain relatively low at 230, as opposed to other times, for example, August and September of 2020. Next slide. So this gives an idea of the clinical disposition of those 230 people. With regards to our recoveries, we would have had 9.8% of them over the recent past. Transferred to facilities 3.1. Those are individuals who would have not decompensated necessarily significantly, but would have showed warning signs that we look out for clinical transfer to hospitals. Symptomatic patients, persons with any type of symptoms, 24.7%, and a large proportion of the 230, 62.4%, now have no symptoms at all and are awaiting their discharge criteria. Next slide. Again, similarly, throughout the epidemic, we have been more or less stable at 49.7, almost 50-50 for males and females. Sometimes the males go up a little more and the females go down, but it's more or less 50-50 throughout the epidemic, and it maintains in that vein. Next slide. So the next slide gives us the percentage comorbidities. Again, we see without comorbidities at 48.3%, and with comorbidities 51.7%, just giving a reflection that anyone can get infected. Getting infected has nothing really, no great association with having a comorbidity. However, having a comorbidity puts you at greater risk of complications of COVID-19. Next slide. Again, we break down the comorbidities further, and we see again diabetes 24.6%, hypertension 45.6%, and asthma 19.3%. If you can remember, previously when I had done this, for example, in St. George West, it had a similar pattern. However, in certain other counties like Caroni and Victoria in the past, predominant cases were diabetic and hypertensive with smaller proportions of asthma. So this is the national picture, gives you asthma, diabetes, and hypertension being the leading comorbidities that people are having at this time. Next slide, last slide. Yeah, so this final slide just gives you the patient distribution by age. And starting from 0 to 19, we see that 12.78% of the persons that are infected are indeed belonging to that category. between the 20 and 39 years and 40 to 59, and throughout the epidemic has accounted for the largest proportion of those infected. If you take both of them together, you're just under 62%. 60 to 79, 24, about a quarter of the infections occurring there, and in the 80 plus we see 1.13%. However, when we look at the fatalities of 80 plus, we see that a lot of fatalities have come, a large percentage of those 80 plus that have been infected have actually succumbed to the illness. So that's my last slide for this morning, Candice. That's the clinical update.
Thank you very much, CMO, and for that reminder that while persons with comorbidities may have the most risk of serious complications from the disease, the fact is that we are all at risk of contracting COVID-19, and we should all follow all of the personal health measures all of the time. And next we go to Professor Montai, who will explore the question, COVID-19 vaccines, can they end the pandemic? We go to Professor.
First slide, please. I'd like to start off by thanking Dr. Parasram for his kind invitation to speak about the COVID-19 vaccines and whether this is our way out of the pandemic. And a very good morning to you all. Next slide, please. So for us to begin to move out of our current situation and back to some degree of normalcy, we really need to do two things. We have to provide the majority of our population with a good level of protective immunity against the SARS-CoV-2, which is the virus that is causing COVID-19. And in addition, we need to have a low transmission of the virus from person to person, so very little of the virus passing from one person to another to cause infection. And I want to suggest to you this morning that the best way of us achieving this is through vaccination, a very good vaccination program. Next slide, please. So for us to begin to think about this, we have to compare what natural immunity, or other words, immunity that comes from having the infection versus vaccine-induced immunity. So the first thing is that if you get SARS-CoV-2 or COVID-19, you will, at the end of it, develop some immunity. The problem is you have to get the infection to get the immunity. And while we know that perhaps the vast majority of persons who get COVID-19 have mild or asymptomatic infection, it works out to about 85%. We do know that about 10% of persons are going to have moderate disease that requires hospitalization, and probably around 5% will need more support, possibly in an intensive care unit. After that, you certainly have immunity. I just want you to look to the right, the upper panel, and the kind of immunity we see following infection with the SARS-CoV-2 is directed against those little spikes that are poking out from the blobs in that photograph. And those spikes are what the virus uses to enter cells, to infect cells and to cause disease. So one consequence of getting the infection is the development of immunity, antibodies against the spike proteins, as well as what we call T-cell responses against those. So we have some idea of what are the components of the immunity that we get following natural infection. We also know now that that protective response on average is probably lasting about 8 months in persons who have had COVID, and likely longer in some people. The good news is that if you are vaccinated, you will not have to go through the problem of being sick. And in fact, because none of the vaccines that are in use now or in development will in fact cause infection. And we also know that these vaccines can generate the same kind of responses that we get following infections. So that what the vaccines are usually doing is showing your immune system a lot of the spike protein. And we know that after vaccination that we develop lots of antibodies against the spike protein. In fact, we are even aware that many of the vaccines give us higher levels of anti-spike protein antibodies as well as T-cell responses. And therefore we believe, and there certainly is evidence towards that because we are developing higher levels of these antibodies against the spike protein, which will stop infection, that actually is likely to continue for more than a year or even longer. So that's good news. We also know that the vaccination prevents against the development of moderate and severe disease and even mild disease. So again, you can get all this protection without getting the infection if you get vaccinated. Now, can infection occur after natural infection, what we'll call reinfection? And yes, it can. There's evidence that even after getting severe COVID-19, you can get another bout of COVID. But the immune system has learned a lesson after the first dose, if you wish, of infection. And the second time you get infected, it's usually far milder. We also know that if you get vaccinated, you do have a small risk of getting infection. It won't be reinfection because you did not get infection once you're vaccinated, but you can get the infection after you've been vaccinated. Now, you would be seeing in the news that there's been a lot of talk about variants. And variants are mutants. What happens is that every time we get infected, a new person gets infected, the virus is making lots of daughters, virions as we call it. And in the process of making all these offspring, there's a likelihood for mutations to develop in the spike proteins. And sometimes the mutations in the spike protein give the virus an advantage. They may become more infectious and may actually be able to cause more significant disease. And we are aware that there are variants that have occurred in the United Kingdom, in South Africa, and in Brazil. And that these variants actually can be a little bit more challenging. We know that after the natural infection, there's some people who have had reinfection have got infection with these variants. So the infection from the natural disease isn't necessarily covering you against getting infection from a variant. The good news is it tended to be milder than the first episode. We are aware so far that the vaccines, certainly the information that is coming out more recently, is that the vaccines such as the Pfizer, the AstraZeneca, Oxford, even the Moderna, are providing quite a good level of protection against these variants. It's a little bit less, but it's still good against these variants. I just want to say that we often think that because we have an immune response against a virus, that it is always a good thing. In fact, viruses often cause the immune response in the immune system in your body to misbehave. And in fact, we are aware that in severe cases of COVID-19, that some of these patients, their immune systems are making antibodies against other parts of their body. In fact, some of this clotting that we have associated with severe COVID-19 may be because the virus has induced these patients to be making antibodies against certain clotting factors. We are also aware that after vaccination, you could also have abnormal immune responses, in this case manifested as allergy, but I will speak about that later. Next slide, please. Now, every time you open the newspaper or you hear the news, there seems to be a new vaccine on the horizon, and that's indeed the case. This is certainly not an exhaustive list, but I want to point out that there are various types of vaccines, and that's a good thing for different populations, but I want to focus a little bit on the AstraZeneca Oxford vaccine and the Pfizer vaccine, since I think these are what we might be getting in Trinidad and Tobago. Next slide, please. So let's start off with the AstraZeneca Oxford. It's a viral vector vaccine, but I want you to think about it as a taxi. And since it's a British vaccine, I have put actually one of the large London cabs as my picture. So the viral vaccine, which is actually an adenovirus, another type of virus, which actually infects chimpanzees and cannot replicate in humans, it's been doctored so it cannot replicate, is the taxi. And we can fill it with precious cargo or with a passenger. And the precious cargo is in fact the blueprint for the spike protein. So what is the taxi? It delivers this precious cargo to human cells, and that precious cargo is put into human cells. The human cells use that blueprint and makes the spike protein from that blueprint. The immune system sees it and makes anti-spike protein antibodies and T-cell responses, which are protective. Next slide, please. So what do we know? There's been a lot of confusion about AstraZeneca Oxford vaccines, but the recent literature is suggesting that this vaccine certainly can give a good level of efficacy, prevent infections in the majority of people. I'm giving an average here of 80%, but the literature is also suggesting up to 91%. We certainly know that it's preventing hospitalizations. If you look at this graph, I just want you to look at the last row. after the second dose of the vaccine, it takes a little while to develop the best immune response, usually 2 to 3 weeks. You will see that while they're in the comparison of the patients who got the vaccine and those who did not get the COVID vaccine, that all 9 patients who were hospitalized actually were in the non-vaccinated group. We do know that that this vaccine prevents hospitalization to a great extent. We are also aware that it seems to be decreasing, or it has the potential to decrease transmission. And how do we know this? We know this because when they were doing the trials with these vaccines, in the group that were vaccinated, in the group that were not vaccinated, they asked them to take nasal swabs every week, and they checked to see whether there were virus in these nasal swabs. And what they found was that the 67% less patients in the vaccinated group had any evidence of virus in their noses, implying that there could be a decrease. These people would not be able to transmit the virus, and therefore we think this could reduce the transmission of virus by up to 67%. So that is amazing news. The good thing about this vaccine is that we can give 2 doses 12 weeks apart. That seems to work very well, and it can be stored in the fridge. So good news on many fronts with this vaccine. Next slide, please. The Pfizer-BioNTech is a different kind of vaccine. It's actually, its blueprint is messenger RNA, and that too has to be delivered into cells. And the formulation of this blueprint is actually put into small fat bubbles, if you wish. These are called liposomes. Very, very tiny liposomes are called nanoparticles, and that's really what this vaccine is put into. So the vaccine is delivered in 2 doses, 3 weeks apart, but we now know you can give it 6 weeks apart, and it's very good. It's going to decrease symptomatic infection in up to 95% of vaccinees. And it definitely, like the previous vaccine, can prevent moderate and severe COVID-19 infection. The main concern about this vaccine is that there have been reports of quite severe allergic responses. So let's look at that a little bit more closely. Next slide, please. Vaccines are very complex mixtures of things. You not only have the active ingredient, in the case of Pfizer, the messenger RNA, but you have other things. You have that lipid coat, that lipid bubble coat that I was speaking about. You have stabilizers, you have other things, and preservatives. So vaccines are always complex. And we are aware from prior experience with other vaccines that allergic reactions can occur in different people to different components within a vaccine. When the vaccine started to be administered from middle of December, the initial monitoring, they looked at the cases of severe allergy after 1.8 million doses had been, in fact, given, and there were 21 cases of anaphylaxis. And anaphylaxis is really severe, very severe allergy and can be life-threatening. So that was something that they had to pay attention to. 81% of the patients who developed anaphylaxis had a history of quite severe allergies, and some of them even had episodes of anaphylaxis before. The good news is that almost the majority of them developed their symptoms within 10 minutes of getting the vaccine, so they were dealt with immediately. Only about 4 actually had to go into hospital for continuous monitoring, and everybody recovered. So there were no deaths, but it is certainly something that one has to be aware of. Next slide, please. Okay, so when we do clinical trials, the clinical trial people, the participants, whether you got the vaccine or you didn't get the vaccine, are monitored very closely. So what is the real world experience of having got the vaccine? Well, Israel is leading the way here. And Israel, at present, has in fact vaccinated over 90% of its population 60 years and over. And what they are, with the Pfizer vaccine, and what they have been able to tell us is that the number of infections following vaccination in this population has just dropped precipitously. So that's very good news. And there are very few hospitalizations in this population, and the number of actual infections seems to be very low. So there's real-world evidence that the vaccine, in this case in Israel, the Pfizer vaccine, is working. And why this is so important is because in Israel at present, there's circulation of both the UK and also the South African variants. So the vaccine seems to be giving some protection against those. Next slide, please. So I would like to argue, and I put it to you, that vaccination is our best way of getting out of the pandemic. Because with vaccination, we will be able to provide a good level of immunity against the SARS-CoV-2. And we will also, as a result of getting more people immune, there'll be less transmission of virus from person to person. And as good Trinidadians, we'll be able to, in the future, if we all get vaccinated, or majority of us, be able to hug and go to our fetes. Thank you.
Thank you so very much, Professor. I am now a little excited about the field of immunology, and I learned so much from your presentation. Thank you very much. I'm pleased now to introduce Nurse Ramlagan to give her perspective on vaccination and the safety of vaccine. She's a senior DHV, and so she's very well poised to give us some information in this regard. We go to Nurse Ramlagan.
Thank you very much. Hi, good morning. Again, my name is Penny Ramlagan. I have been in the field of nursing for more than 10 years. Currently, I'm a senior district health visitor at the Eastern Regional Health Authority, and I am an advocate for vaccination, and I'll tell you why. Firstly, vaccination is effective. If we look at the historical process of vaccination, it is evident that vaccination has made a significant impact in allowing us and other countries to receive optimal health for our population. Vaccination commenced in Trinidad and Tobago over many decades ago in the aid to combat death and severe illness from vaccine-preventable diseases like polio in 1971 and also measles, mumps, and rubella. And yes, vaccines have been effective, with not a single case recorded in polio in the last 40 to 50 years. Vaccinations are not new to us in Trinidad and Tobago. Our parents, our grandparents, and even our great-grandparents utilize vaccines. We also know that some vaccines are required for travel, example, yellow fever, all in an effort to protect countries from outbreaks. So we would all agree that vaccination is not a new way of protecting individuals and countries. I would also like to mention that Trinidad and Tobago, over the years, has continued to maintain an over 95% status of vaccination, as documented in WHO studies. So that alone illustrates the confidence that we as a country have with regards to vaccination. Secondly, vaccination is safe. Making sure vaccines are safe is a priority for WHO and other global institutions, such as the CDC and FDA. Vaccines undergo a series of steps to ensure its safety and efficacy for use by the public. These regulatory standards have been in place for over decades and have been effective in maintaining the safety and standards of vaccines. So yes, we can trust these regulatory standards that ensure that vaccines are safe before issuing the public. The American Academy of Pediatrics, the American Academy of Family Physicians, Center of Disease Control and Prevention, World Health Organization, and Pan American Organization, all reputable health organizations, all recommend vaccination. As I mentioned before, I have been in nursing for over a decade and more, and have never had chance or had the need, to fill out the ISAVI form for a vaccine, because these regulatory standards ensure that vaccines are indeed safe, and the COVID-19 vaccine would have gone through the same regulatory standards to ensure that safety and efficacy standards are maintained. Thirdly, vaccination is our first line of defense. All throughout history, vaccination has been our ammunition in the combat against vaccine-preventable diseases. Vaccination is recorded by WHO as the single most cost-effective method in the combat of vaccine-preventable diseases. We don't just vaccinate to protect our children, we vaccinate to protect our future, our grandchildren and great-grandchildren. The COVID-19 vaccine is a major line of defense in the fight against the COVID-19 virus. The COVID-19 vaccine, together with adherence of the COVID-19 protocols like mask wearing, social distancing, washing of hands, sanitizing of hands, will help us win this war against COVID-19. Fourthly, vaccination saves lives. Make an informed decision. Don't let rumors and myths prevent you from making an informed decision. Gather the facts and make an informed decision. I will give you an example. In 1974 in Japan, 80% of children were vaccinated against pertussis. And in that year, only 393 cases of pertussis were reported and 0 deaths. However, rumors of the vaccine being irrelevant and not safe spread across Japan in 1976, and only 10% of the children were vaccinated, resulting in a pertussis outbreak of 13,000 cases and 41 deaths. In 1981, vaccination rates increased and pertussis was eradicated from Japan. Similarly, some people argue that COVID-19 vaccine is irrelevant because the numbers are currently low, and they question the safety of the vaccine. Doesn't this sound familiar? So my question to you, are we willing to face the repercussions as Japan did? My advice is to gather factual information, listen to your healthcare providers, and make an informed decision. In closing, stopping a pandemic requires using all the resources and tools available. Vaccines are effective. Vaccines are safe. The regulatory systems that we have been trusting for decades to ensure vaccine safety is the same that exists today. And safety is always the #1 priority. I will be taking the COVID-19 vaccine when it becomes available. And I encourage my colleagues, my family, and you, my clients, to make an informed decision and debunk the myths of vaccination. Thank you.
Thank you very much, Nurse Ramlagan, for that very infectious confidence in vaccination. We thank you so much. And I say again, make an informed decision, please. And this is the time now where we get to give you even more information as we respond to questions from the media. Please state your name and the media house that you represent before posing 2 brief questions, please, and both questions at the same time. Of course, if we have additional time, we will accept more questions. We begin with questions from AZP News.
News.com. My first question is for Professor Mondine. Professor, when we hear, for example, that the AstraZeneca vaccine is between 60 to 70% effective, does that mean the efficacy rate? Does that mean, for example, that out of every 10 people who gets this vaccine, only 6 or 7 would be properly immunized and be fully protected from COVID-19? That's my first question, just to explain that. And my second question is for the CMO. CMO, we had no cases recorded, I think, from samples from February 2nd to the 4th. That period. What do you think caused that? No cases to be recorded. Thank you.
Okay.
Thank you so much for your question, for your really excellent question. So how do they do the trials? Essentially, what most of the trials have done is that they have a group that are vaccinated and a group that are not vaccinated, and with the COVID vaccine. And what they do is that they monitor them for the development of symptoms. All right? So let's take your example of 10. So 10 people have received the COVID-19 vaccine, and we're monitoring them for the development of symptoms. Well, what they have found is that, in fact, you're right, that perhaps 7 of them developed no symptoms, but 3 had symptoms. Now, what do we mean by symptoms? It could be very, very mild, or in the case of AstraZeneca, they were actually doing the nasal swabs. So they were detecting asymptomatic infection. So that is effectively what we mean to some extent by efficacy. It is between the vaccines and the development of symptoms. Now, there are reasons. When you vaccinate, everybody does not develop great immune responses. There are various reasons. Well, elderly people might not. The very young might not. You might have people who are on different kinds of medicines, have certain comorbidities, so that maybe immunosuppressives or whatever. So they might not be able to develop very good responses and therefore might not be as protective as others. So I hope that sort of helps you in. But what I want to say actually is that more recently they have provided more data from AstraZeneca. And what is interesting about their data is that following their vaccines, they need time. The immune system does give you a good response, but it seems to need a little bit more time. And they are now quoting higher figures. And their figures, that's why I gave you the efficacy rate of about 80%, though it can be as much as 91% in certain subpopulations. So just to add that.
Okay. So again, we would have had no cases. You noted before, I think it would have made the front of the news some months ago when we had no cases reported in a 24-hour period. I'm happy to not see it at the front of the news this time. But what it means, it is a good sign. So we would have, over that particular period, I asked the lab, we would have tested about 231 samples, and reminding the population those samples would have been taken from individuals that presented to the facilities usually with some sort of viral-like symptoms belonging to the category of AVI, acute viral illness, or acute respiratory illness, or severe SARI, which is severe respiratory illness that presents to the hospital. So in those individuals, out of all of them that were tested, 231, none of them came back as positive over that period. So as simple as that, we didn't pick up any positive cases over the last 24 hours testing that sample size. Doesn't mean that we have no COVID in the country. We have, as I went through in detail, we had 230 active cases at this time, and I'm sure we have persons presenting to the facilities with viral-like symptoms that will be tested, and possibly by tomorrow you'll pick up another few cases of COVID in Trinidad and Tobago.
Thank you very much, CMO. And we go now to CL Communication, please.
Hi, good morning. Natalie Singh, CL Communications. Just trying to find out, has the logistics concerning bringing in the vaccines into the country been worked out? What role does Caribbean Airlines have to play in this regard? And then secondly, is Trinidad going to do an education campaign to sensitize the public more about the positives when it comes to taking the vaccine? Thank you.
Yeah, so in terms of the vaccine coming into the country, normally what happens is the Pan American Health Organization, through the revolving fund, we actually purchase vaccines through PAHO. They have a standard sort of courier system that they rely on, and I asked the question of them last week or this week whether they will be considering other couriers. I think they will be sticking to their normal couriers to bring the vaccine into the country. We have worked out the process from pre-arrival all the way to administration in our national vaccine plan. So there's a full plan that actually goes through step by step what happens. Right now at the Couva District Health Facility, we are doing a mock drill, actually going through with the senior staff at the Ministry of Health as to how the vaccines will be rolled out from actually storage all the way to delivery to a patient and different scenarios. So they're doing that. They started at 9 this morning, should be completed at 3 o'clock this afternoon. So with regards to CAL, we have received some correspondence from CAL, and we would have responded in that regard.
And so I guess I'll take the second question. Yes, there will be a very public campaign. Of course, we've already begun with conferences like these. Right now, there's a lot of focus on the internal campaign. As you can imagine, our healthcare workers and our stakeholders are critical. Tomorrow, there is a virtual symposium on the vaccine for health persons in the healthcare sector and stakeholders in the private sector and civil society. We go next to TV6, please.
Good morning, Alicia Boucher from TV6 here. My first question is to Professor Montai. Professor Montai, I know with the Pfizer-BioNTech vaccine, it provides up to 95% efficacy. I think you said AstraZeneca can be anywhere between 80 and 91, do we know how much your body's natural immunity, when compared to that kind of efficacy, how high your body's immunity can reach if you do happen to contract the virus and develop natural immunity? So that's my first question. The second question is, I'm seeing that AstraZeneca, persons who are allergic to polysorbate 80 should not take that vaccine. Do we have any other elements that people should be aware of in terms of taking the AstraZeneca vaccine? And if so, then we know that the Pfizer vaccine, they're unable, if you have food allergies, you should not take it, severe food allergies. Is there any other vaccine at this point that, they would be able to take? I know it has to be approved by the WHO, though.
Well, I'm not absolutely sure that I agree totally with what you just said, but okay, let's come back to the first question. You're asking me whether or not that vaccine immunity provides more than natural immunity. I just want to be sure what you're specifically asking. So you said if you get the vaccine, yes, let's say the Pfizer-BioNTech, yeah, is it that and it's 95% effective? Is it that it's better than natural? Is that what you're asking me?
No, I'm asking if your body's natural immunity can actually get up to that level where it could provide as much as a 95% efficacy against contracting the virus.
Well, again, when we work out efficacy, when they speak about a virus efficacy, they're really looking at how many people in a group they have stopped getting the symptoms or evidence of infection. All right. Now, certainly, when they are doing their tests, they take convalescent plasma from the person who has had the natural infection, so from a group of people who have had natural infection, and they look to see what level of anti-spike antibodies they have. I just want to say we have been using anti-spike antibodies, and that's an easy way of measuring a person's immunity, but it's far from the whole story. Your body does a whole heap more than that, so it's not necessarily the best way of determining a person's immunity. So just to put that out there. And what they then do is that they do the measurement of the same anti-spike antibodies after they're vaccinated people. And what they have found is post-vaccination, as a whole, generally, people who have been vaccinated tend to have higher levels of anti-spike antibodies than people who have recovered from the infection. It doesn't mean that in that group, it's like any spectrum. Some people are going to produce very high levels after their natural infection of the spike antibodies that may be equivalent to what you get after vaccination. But there are those that actually have very low antibody levels, yes? So they are comparing the vaccinees with those. So essentially right now, we believe that quantitatively, that the vaccinees are actually making higher levels of the antibodies against spike. And that's why they're optimistic that while we lose that in fact we're probably going to provide protection for a longer time. And vaccines in the past, something like measles, the vaccine actually gives you perhaps even better immunity than your immune system. So that was one. The other thing too is that certainly polysorbates are in a lot of things. Polysorbates are in a lot of medicines and a lot of other vaccines. I didn't hear that you had, I didn't hear, but maybe I didn't read the right literature, maybe somebody else did, that if you have an immune response to polysorbates, then you probably will have to be careful with more vaccines, and you've probably had bad responses to previous vaccines because polysorbates is in a lot of different medications. Certainly the PEG is what they're thinking about with the Pfizer and the Moderna, because it's part of the stabilizing for the lipid coat. But it doesn't necessarily, not because you have food allergy, means that you cannot get those vaccines. Someone who has had severe allergy, probably we have to be careful, and they cannot be done probably in a health center. We'd have to, on an individual basis, determine how severe that allergy is, and then decide what we need to do. But you raise a very good point. There are lots of different vaccines that are coming up, and some people cannot take certain vaccines, so we will have to get others for them. But what I'm saying is that I think that the evidence is that people with severe allergy, a lot of them have actually got the vaccines quite quite well. And I don't know that severe food allergy is a contraindication to, let's say, the AstraZeneca. So I have to say that there's a need, though, for different vaccines for different people.
Thank you very much. And we go to a follow-up question from CL Communication, please.
Right. Hi. I just wanted to find out, Israel has gotten it correct. So what can Trinidad learn from Israel, if at all anything? Thanks.
Okay. So we have a similar vaccination strategy in terms of who we want to vaccinate. We want to vaccinate our healthcare workers. We want to vaccinate those over 60. We can put all the plans in place. We can have our systems in place where we deliver X amount of vaccines over a given period of time, and we have all these grand plans. If people don't come to the table and take the vaccine, then all the plans fall down. So I think a lot of it is reliant on, and we are trying to build, that sort of, as Nurse would have said, look at the information before you and make an informed choice as to whether you should or should not take the vaccine. So really and truly, we depend on the population, and we're making a clarion call to everyone that if we are to end the pandemic in Trinidad and other parts of the world, that we have to take the vaccine. And evidence from Israel has showed us that it can even happen in a very short space of time in terms of the way the people are being infected and the severe infections. So we are actually having Israel has reached out to other member states so that we can actually learn from what they have done. And we are having a video conference with them in the near future to see what happened in Israel and to see if we can mimic some of their logistical strategies. But again, it all comes down to a population that's willing to accept the vaccine and getting, if they are able to get 90% in Trinidad, I'm sure we'll have a similar response to as Israel did in terms of protecting our population.
Thank you, CMO. And just to follow up, what are some of the positives that we are seeing from the Israeli experience between yourself and Professor Montai, maybe? What's happening in Israel that's so encouraging?
Well, I have to say they were very smart. They negotiated with Pfizer even before the vaccines roll out to get the vaccines, because they were going to use their country as the pilot or as a testing ground. So they were very smart. Nonetheless, but it comes back to what Dr. Parasram has said. 90% of people over 60 in Israel have been vaccinated. That is a high uptake. It means that people are going out to get the vaccines. They're now rolling it out to other age groups. Sure, they're still dealing with other groups, younger patients. Why do I need the vaccine, etc. But the point is that they generally, because they're seeing that it is safe, and that the people who are vaccinated are not going into hospital, more and more people are going to take up the vaccine. So I think that yes, I would say that that's what we have learned from them.
Thank you very much.
Yes, Candice. Just to add a little bit, and what Trinidad has been waiting for is WHO's approval for Pfizer. As you know, we have signed up to the COVAX, and we have had bilateral talks with Pfizer as well. And we are hopeful that through both mechanisms, later down the line, we should get some portion of Pfizer vaccine in the country as well. But again, Trinidad is reliant on the regulatory process and has always been, and we will only use something that has been pre-approved by WHO through their mechanisms. And we don't want to preempt any approval. We don't rely on stringent regulatory authorities in disregard for this particular vaccine. We just want to make abundantly sure that the regulatory process has gone the full way before we begin to use. And as Minister and myself had said before, we have the benefit of seeing what is happening in the rest of the world, being a month or so behind, seeing the research in a real world setting, seeing the adverse reactions, seeing what has worked and what has not worked. And I think that benefit will go a long way in making sure that our vaccine initiative is tailored to the people of Trinidad and Tobago.
Thank you very much, CMO. We have a follow-up question from AZP News.
Morning again. I just wanted, get a clarification. Is it that the AstraZeneca vaccine can be given to people who have severe allergies? Is that okay for that in this case? Thanks.
I have to say that I am not aware of a lot of allergies associated with the AstraZeneca. Maybe I haven't read the literature that you all have read, but certainly the issue of allergies has been raised very much with the Pfizer and the Moderna. Like everything else, there will be people who will not be able to take a vaccine, but somehow I haven't really seen the level of allergy with the AstraZeneca as one has seen with the Pfizer Moderna, but maybe I just haven't seen it. I don't know what you've seen, Dr. Paris.
No, so I don't think it is contraindicated in the same way. So you really see that stand out with Pfizer, that we have to put the checks and balances in place for what we have done in Trinidad, if we do get Pfizer, is to put a process in place where persons will have to wait post-vaccination for at least 30 minutes. In any of our facilities, they'll be monitored, and after the 30 minutes, they will be allowed to go. And of course, we will have the medical personnel and the ambulances and all of those things on standby in the event that people do have allergic reactions. So we have seen it with Pfizer, and we're putting the checks and balances in place. And I think we will maintain it even with other vaccines as they come in. We won't drop our guard with that as yet. But again, we haven't seen that sort of allergic reaction occurring with AstraZeneca as has been seen with Pfizer.
Thank you, CMO and Professor. We go to CL Communications again, please.
Hi. Just wanted to find out if you can give an update on the repatriation process, especially when it comes to the health facilities and when it comes to the volumes of people who are coming back home from overseas. Thanks.
So I'm not sure if I got the question right. In terms of our protocols for re-entry by way of quarantine remains more or less the same. There hasn't been any significant change. For high and medium risk countries, we require persons to be in state or state-supervised quarantine facilities for 7 days, in the instance of UK for 14 days at this time, and with the requisite PCR tests, and then they complete their periods at home for the remaining 7 days for those that do 7 days. With regards to the repatriation lists, those come to the Ministry of Health through National Security, and is really a function of that entity, not Ministry of Health.
Thank you, CMO. We've been talking a lot about the antibody response from vaccination. But why would people still have to continue to follow all the new normal guidelines even after they're vaccinated?
Okay. All right.
Okay, so I mean, I could start off. You could go into the technical bits, but I mean, as we have said before, when we begin vaccination, we have to get to a state where we are at herd immunity in the country, where we can have a population that is well protected by way of antibodies, so we don't have spread occurring from one individual to the next, before we can decide to drop our guard significantly or otherwise. We also have to have research that suggests that the antibody response from vaccines lasts for a great length of time. So with vaccination so far, because they are fairly new, we only have 8 months, 8 months of data. So we don't know how long the vaccination induced immunity is going to last in the population. So for two reasons. We're not going to go from 0 to 100% in one day. So it will take us time to vaccinate a significant proportion of the population to get us to herd immunity, at which time, of course, we will decide if and when the public health measures are to be reduced, and as we have done before, scale it back. But until we are confident that we have reached to that state, we have to do both things in tandem. Vaccination is a very large part of the public health response, but is not the only, and the others have to be maintained until such a time where we can feel safe by way of herd immunity. You have anything else?
No, I generally agree. In fact, I was just thinking that in Israel's data, while they have immunized 90% of the 60 years and above, and yes, they have a massively decreased level of hospitalization, there still are people who are getting hospitalized. So it really speaks to the fact that you can't just do one group. It's really the whole country that has to be highly immunized, because these people are still getting the infection from somewhere, and they're still susceptible people even in that group that have been immunized. And that's what herd immunity is. It's really that the majority of us have good immunity so that we have less transmission of the virus, and in that way protecting those who cannot make good responses. Cannot, for whatever reason, they need to be protected, and to do that, the whole country has to be involved. And so this is really a clarion call to everybody in Trinidad to think. We haven't got the information yet for kids. Those trials are being done, and we haven't got the information for pregnant and lactating women. Those trials are being done, but every other adult in this country seriously has to think about getting the vaccine. One of the vaccines against COVID, against SARS-CoV, in order to bring about that level of protection.
Thank you very much. And I just wanted to go to our senior DHV, who's here with us, who's been vaccinating persons for many years. Just wondering, what is the most common side effect you have seen, Nurse Ramlagan, from vaccination over the years?
Hi. Well, side effect, I would say that most persons get mixed up basically with side effects. I would say that, when you are vaccinated, we expect a response, immunological response. So most patients will get fever, they may get sometimes irritation at the site, and those are things we expect, especially the fever, because it tells us that you are building an immunological response. So side effects, I have never seen a client with a side effect from a vaccine, as I mentioned before. Never had chance to fill out the ISAVI form because there were no side effects. We do, however, expect basic immunological response, which is like fever and so forth.
Thank you very much, everyone, for joining us for today's media conference. We have come to the end. We really do appreciate that you take the time to view these conferences every week. I know today was very informative. We have Professor with us, CMO and Nurse Ramlagan. Thank you very much for sharing your knowledge and your experience. Remember, we are all in this together. Be safe, enjoy the rest of your day, get ready to get vaccinated, and please wear your mask.
The majority of transmission that we know about is that people who have symptoms transmit the virus to other people through infectious droplets. But there are a subset of people who don't develop symptoms. And to truly understand how many people don't have symptoms